begin by saying that I am Judy Hearn. I'm pleased to represent Midwest Business Group on Health as the Director of Membership Initiatives. Assisting me in the webinar today is Christine Evans, who is our office administrator. So today's agenda is up on the screen. If people can just confirm through the chat that they can see the agenda and that you can hear us, I would appreciate that. Due to the large number of participants that we have today, we will be using the chat feature only to manage any questions throughout the webinar. So we will give you some opportunity here and there to ask questions. So please send them on through the chat as you think of them, and then we will pull them throughout the program. Okay, let me begin. Okay, let me begin first. I'm sorry, I've got something there you didn't want to see. I'm going to start first by showing you who our folks are. That's a picture of me from Midwest Business Group on Health. I'm very pleased to welcome as our first guest speaker today, Tara Sherman from the Boeing Company. She's a member of the Health and Wellbeing Strategy Team. She leads the development of strategy for both the U.S. and internationally. So I'm going to leave that up for just a second. Welcome, Tara, and she'll be speaking in a few moments. Also, welcoming guest speakers Sarah Downs from WellSpark and Ron McClellan from the Connecticut State Service. You can see who they are, and again, they will be speaking a little later in the program. So I'm so excited to have everyone on board with us during this webinar. Just a couple of comments about Midwest Business Group on Health. We have over 120 members represented by health benefit professionals from mid, large, and jumbo employers. We also include as our members, my slides are jumping, which they were not supposed to do, so excuse me for that. Our membership spends more than $4.5 billion annually on health benefits for over 4 million lives, and we focus primarily on education. So here's just a couple of upcoming events. We have our annual conference next week. We are doing another session on the pre-diabetes and diabetes management webinar on on May the 30th. It will be the same content as today. And then we have programs on the pharmacy benefits and specialty drugs in June on the 12th. And then we will be doing an in-person workshop on the pre-diabetes and diabetes management for our Southern Illinois constituents at the John A. Logan College in Carterville, Illinois. That is an in-person session. It will not be a webinar. Anyone who can be there in person, we encourage you to be there, and I look forward to meeting folks in person. So our session overview today, this is a webinar brought to you by a CDC-funded grant through the Illinois Department of Public Health that was awarded to the Midwest Business Group on Health. And again, sorry that my slides are jumping. Our goal for the session is to speak about diabetes and the diabetes prevention program to increase awareness, especially for the employers, and to give you an opportunity to take a look at our toolkit. And I'll show you a couple things through some slides, and then I'm actually going to go onto our web directly so you can see how the toolkit functions. So at first here we have a couple of fast facts on diabetes and prediabetes. I think a number of you are probably well aware of these fast facts, so I'm not going to spend a lot of time on them because I think we're preaching to the choir for the most part. So let's look here at some health disparities. And let me just jump back there to make sure I didn't miss one. The interesting thing with diabetes is that some people are affected by prediabetes and diabetes more than other groups. And it's important to be aware that differences in their health status or access to health care varies among racial, ethnic, geographic, and socioeconomic groups. And that's what we refer to as health disparities in diabetes. So the chart that I'm showing you now shows the percentage of diagnosed diabetes in these 5 ethnic groups. The estimates in the chart don't differentiate between type 1 and type 2. However, because type 2 diabetes accounts for 90 to 95% of all diabetes cases, the data presented in the chart is likely to be more characteristic of type 2 diabetes. So here is a chart that shows the level of education. So the lower the level of education, the higher the rate of diagnosed diabetes. And health disparities seems to be a more and more prominent topic as we look at chronic diseases overall, but it's particularly interesting in diabetes. And one other thing I'll mention, the rates of diabetes continue to increase throughout our country, despite new drugs and therapies. Type 2 diabetes can be prevented, and in some cases, even reversed. So diabetes is the most expensive chronic health condition in the United States. Medical expenses for people with diabetes cost approximately $9,600 more annually than individuals who don't have diabetes. And that is according to the American Diabetes Association. So I'm going to jump now into our toolkit. I've had inquiries already about whether we will have the slides available later. And yes, they will be available later in the program, or I'll actually send them out following the webinar. So if you're interested, you can certainly access them then at that time. One thing I want to do first is I want to play you a video. So I'm hoping this is going to function appropriately. And we want to give you a perspective on employer feedback on the Midwest Business Group on Health Diabetes Toolkit. Let's see. Here we go.
We have a huge workforce that's right in that sweet spot. It's either at an age where they're going to have prediabetes or be at risk for that, or have full-blown diabetes.
I think MBGH has really done a great job of bringing awareness to the problem of type 2 diabetes, and it also helped us sort of more laser focus on treatments that are available, as well as some of the current programs in place that are available through other vendors that help manage diabetes in our population.
Diabetes is one of the conditions I feel is the most difficult to manage from a personal level and one of the most challenging from a company perspective. By using the MBGH toolkit, I'm getting credible information and research from experts in the field that I don't have time to obtain on my own.
we have put out a diabetes management toolkit on our website, which is accessible to anyone, members or not. And we are adding employer case studies to show how employers are making improvements and reducing their health costs for those related to diabetes.
The toolkit that MBGH has developed with diabetes in mind has really helped us message to our workforce that's looking at this problem. So to take that toolkit and really develop concepts around it, and the toolkit helps us refine our response to it.
All right. So hopefully you're all able to hear that. This gives you a perspective of what our toolkit looks like when you actually go to the website. And I want to make sure that everyone knows, I don't know if you can see my cursor up here, but how to use the toolkit is a special function. And I forgot I'm not live on this one. I'll show it to you in a moment. It's an easy to use document that actually shows you section by section how you may want to view the content and the recommended documents and resources of each. So I'm going to now take us to the live toolkit. So give me a moment as I jump to that. All right. Make this just a little bit bigger so hopefully everyone can see it. So as we go to the document I was referring to, how to use the toolkit is this little button at the top of the screen, and it actually opens up and gives you a checklist, and this is specifically designed for employers in particular, so it helps them to see section by section what they might want to look at if they feel like they need a little bit of guidance for the toolkit. We realize that employers have different size levels of population that they serve. They also may have different levels of sophistication as far as their understanding with diabetes and chronic diseases in general. And so that's why we put together this document, and anyone can pull this up directly from the toolkit and use it as you manage your way through it. So here we are, back with each section. Excuse me. So building the business case is first, and as you can see, when I move my cursor, I can either click directly on certain elements, or I can just click learn more, and it brings me then, or there we go, brings me to that particular section and information. Now, I'll also point out why employers should care. This blue button here at the top will take you to the video that I just showed you. So you can review the video at any time. And you can share that video with others in your organization, your C-suite, whatever, and I can make sure that you get links to each of the videos as you would like. So back to building the business case. Some small to mid-size employers may need to create a business case for their executive team when they're seeking approval to add or expand a prediabetes or a diabetes management program. So this section will give you questions to ask, access to resources such as the Center for Disease Control's Diabetes Prevention Impact Toolkit, where you can actually figure out how to determine what your diabetes percentage may well be, and that's what I mentioned right here. I'm not going to go into everything that I speak about, but I just wanted to give you some familiarity. Also, along this top part here, This is what we lovingly call our hot dog. At any point, you can go backwards and forwards to the toolkit. So if you want to go back to that home screen so you can see everything, you can certainly do that. So now I'm going to jump to program strategies. I'm going to click on Learn More. An employer who is new to offering disease-specific management programs would probably want to look here to see what basic strategies they may want to build a program that would be optimal for their specific population. Not everyone is the same. So we've got different sections here, role of stakeholders, identifying your target population, choosing the right program, and then all kinds of tools and resources that you may want to use while determining what your strategy might be. Now I'm going to jump on to plan design. And this particular section, we always have little boxes within. If you're interested in using value-based designs and incentives, we often find that when trying to engage participants, sometimes incentives work best. Sometimes they can be a mug or a t-shirt, and sometimes it means waiving copays for diabetes medications or visits to physicians. There are different ways to use incentives, and this section will allow you to see what some of them are doing. We also have employer case studies here, so you can click on that and you will see different program details. Taking Control of Your Health is a program that the Midwest Business Group has been involved in since 2006. And we have some blinded clinical outcomes from using that program. I'm going to make this just a little bit bigger. You probably can't see it well otherwise. So this is all within the toolkit. We've got other employer case studies where you can get some information. And as we gather more information, we always are adding it to our toolkit. This is a living, breathing document. So let's go on to communication. So if you are looking for sample communications, emails, posters, videos that you can use, look no further. You can find it here in our communication section. So we have, I'm just going to pull up the tools and templates here, customizable tools, where we've actually created for you some newsletter articles, posters, and then we have videos that you can show at the workplace. And we have fact sheets, all kinds of wonderful things that come from different places. So it's fun to check out and see what we have here. And again, use of the toolkit is completely free. It's open to anyone on our website. No login is required to have access to it. So evaluation section. When you include evaluation and measurement in your program strategy, you are then able to measure change overall or in a specific population. You can demonstrate value to your organization. You can get feedback to improve your program, and you can compare the success of different initiatives. So this section here will give you some evaluation strategy, some survey results that MBGH did, and again, additional tools and resources. And we have right here in the section where it says click here by my cursor, general recommendations from Centers for Disease Control. So we use a lot of other resources throughout our toolkit that it's all in one easy to find place. You may have noticed as I went through the different sections that each of them contain their own tools and resource box, but here in this final section, you will see that we have combined all of the links and resources, anything that you want to know, and we show them to you section by section. There's also another link here to find that how to use the toolkit. And then we go section by section, the links that, excuse me, hey boys, don't fail me now. Building the business case, the program strategies, and so forth. So I think I mentioned to you before that we have a this is a living, breathing document. I'm going to jump back here to our main section. There we go. Whoops. These newfangled computers, I'll say that, somehow don't, there we go, that's what I need. We have a section here which shows that you can take our survey, and that's not just something that's going to get you spam email in the future, but we actually want to know what you think about the survey. Was it helpful if you used it? Were there particular sections that you felt something was missing? So if you click on that blue box after taking a look at the survey live, we'd love to hear from you, and that will automatically send us your feedback so that we can improve it. If you have a case that you want us to include or other information, we would love to do that. So I am going to take just a minute here. Christine, do we have any messages in the chat?
Nope, not at this time.
Wonderful. So that means Tara, if Tara Sherman is ready, we're going to get Tara up on the screen. And anyone who doesn't have their phone or computer muted, we are getting just a little background noise. But I'm going to turn it over to Tara Sherman from the Boeing Company. Just let me know and I can move your slide.
Perfect. You can go to the first one. We'll go ahead and jump right in. Thank you, and I'm really happy to be here with everyone on this beautiful spring morning in Chicago. Anybody else located in Chicago looking out their window probably feels the same way about today. So I'm really happy to be able to share a part of our well-being program and a part of our diabetes prevention with everybody today. And it may seem a little odd that I'm popping up a weight management strategy when we're focused on diabetes prevention, but the program I'm going to focus on today is Omada, and we actually brought them in as part of our weight management strategy, knowing that it also was a DPP program, and we were getting a little bit more bang for our buck than just a standard weight loss program. So I just hit on a couple key components of our strategy. The individual virtual resources is what we'll talk about today with Omada. We did do some on-site program partnerships with hospitals, and I'll just take 1 minute at the end to chat about those and some key parts of that program. But that's where we had a shared accountability incentive strategy in place because they are typically a lot more expensive than the virtual programs, and we found that we had longer engagement from our employees when they had a little bit of skin in the game and ability to earn their money back, actually. There needs to be a lot of cultural and site support we've seen, so we do partnerships with our cafeteria provider to make sure that we have well-being identified food in all the cafeterias. It doesn't mean that there's not a fryer or cake sometimes, but we do try to make healthy choices easier choices for our employees. We have clinical obesity program. We have a center of excellence for bariatric surgery and other areas covered through our health plan. And we also make sure that every program we bring in has some type of mental health component in it, because we know there's such a connection between mental health and diabetes or obesity. And so we want to make sure that we start to hit on that and identify any barriers that there may be. Go to the next slide. And this just kind of shows how we enable our strategy. Some of these items I talked through. But again, we try to bring to life an environment, both virtual and at the sites, that really support employees in their quest for better health, be it nutritional, physical activity, or any different areas. So we have great support at the bottom. Our CEO is a big cyclist, and so he hosts cycling mornings at many of the sites when he goes to them. I can't keep up, so I haven't gone yet. It's a goal. And anyone can go, but I feel too embarrassed to turn around when they're coming back. So let's see. Physical activity challenges is another really big part of our culture that does help support weight management. It's really interesting. We have a program called Bowing on the Move. It's a fairly typical steps challenge, but it has become the foundation for well-being. It's what people think of when they think of well-being, and it's become such a huge part of our culture that someone in my department told me that there was a Reddit thread, which is way too, I think it's a different generation than me on Reddit, but it was interesting that people were asking where Bowing on the Move is this year and when it is. And so it's just, it's really become, like I said, a foundation for us, and the leaders get involved in things like that too. So my point here is kind of just showing the different avenues that can help support some of these programs that, that we put in place. So the next slide. So the focus of today for me is on Omada. And we partnered with Omada in 2015 is when we started working with them, and we did a small pilot at 2 of our sites in Oklahoma City and in Mesa, Arizona. It went really well, and so we went live with the whole company the beginning of 2016. So Omada is an online weight management and health risk reduction program. As I said, we brought it in and communicated it more on the weight management side. And it guides people through making modest lifestyle changes that can be sustained, because all of us know the many different diets or programs out there that can be pretty dramatic. And we all know, those of us and others that have tried them, and what the results are in the long term. Not that great. So the key part of this program is very small changes that can be kept up. It combines technology, a human coach, weekly lessons, and a virtual group support. The foundation of the program is 16 weeks, and during that time there is more interaction and guidance from the coach, and more depth in the lessons. So they may take 15 to 20 minutes to complete, versus after you pass the initial 4 months, the next 8 months, there continue to be lessons, but they're much shorter sound bites, and the coach is still there, but they're more letting the participant drive the interaction. Participants track what they eat, drink, and do each day. It's free form. It's not like MyFitnessPal with calories or anything, but it's just to look at what you're eating and how it impacts how you feel, your weight, and your activity. This was a first for us, that not all employees were eligible. And what I mean by that is anybody was eligible to go in and apply for the program, but Omada had certain criteria in order to be accepted into the program. So there needed to be weight and one other clinical risk, such as high cholesterol or high glucose. We actually worked with them. Now employees can get in based off just a high BMI, but when we launched it, that wasn't the case, but we felt really strongly and worked with them to have, I think it was any employee over 27 BMI could join. And the reason for that was, again, focusing on diabetes prevention. We wanted to make sure that if somebody was on that trajectory, that they had support to stay healthy and kind of reverse that I say progress in not a positive way. We communicated it through many channels, as I'm sure many of you do, including our intranet, our internal news, and e-posters, and in our well-being newsletters that we had at the time. We also used employee testimonials. So from that pilot group, we were able to find employees that were successful and share those stories at the launch, at the larger launch. And we also did offer an incentive. It was for completion of 9 lessons, and employees earned a $100 gift card if they made that completion. So I wanted to back up to show you results from not just last year, but information from the past years, because we've seen some pretty big swings. And I just thought for anyone looking to start a program that it might be interesting to know in case you experience the same thing, or if you haven't, then I probably should talk to you and then learn how you've sustained kind of stability, because we've just seen some very different things go on. So the first year that we launched in 2016, you can see we had almost 6,000 people apply to the program, and of that 5,800 that group was past week 16 when they looked at this information. And then you can see how many of those people completed 4 lessons or 9 lessons. That becomes important because we start looking at engagement and weight loss connected to that lesson completion. So 2016, you see, was gangbusters. There was obviously pent-up demand and a lot of interest in this. It was the first real solid weight loss program that we brought in, and definitely the first virtual program using technology. But then what happened in 2017 is we saw this dramatic drop-off. So from 6,000 people applying to just 1,500, was a really big difference. And we still had that $100 gift card. We still were sharing the program, but we just didn't get as much uptake. And others may experience this too, but no matter how much we put programs out there and we feel like we're over communicating sometimes, we'll still find out that people didn't know we still had the program. They thought it was only for a year or two. But we didn't change our communication tactics or incentive in that year. So that was really interesting to me. The 2017 outcomes, though, were really good. So even though we had smaller numbers, we were extremely pleased with what we saw. So you can see here the average weight loss at week 16 was 4.1%, 26 was 4.2, and maintained at 3.5% at week 52. You might think, well, but it went back down. Why are you so happy? And the reason I'm so happy with this is the only other program of reference we had was that was semi-virtual, didn't have technology involved, but we saw a less than 1% weight loss. We did a pilot, and we did not consider that successful. We've done a couple on-site programs, and those range between 2 and 5% at 12 weeks. The beauty of this program is we saw really great weight loss in the first 6 months, and then it was maintained. So even though a little bit of weight was gained back, we were able to see for the first time really what those results are. Before that, we had no idea at all. So it's really interesting, and that's where some of the virtual things come in very handy, because people really get addicted to the scale that records their weight, and while it's recording their weight, we get to still see what's happening with their success down the road. So then you look at 2018. We went from 1,500 back up to 42. So what happened this year? We introduced a well-being technology integrator and a brand new rewards program. So employees were able to get points for watching a video in a number of different things. But if I focus on Omada, applying for the program and then completing 4 lessons and 9 lessons, and then some others in the post 4-week time frame. So we saw a lot more enrollment again. So one would think, wonderful. in 2 slides, we'll talk deeper. I should have I should have reversed those. But this is also the platform and program engagement from last year. We've seen a little bit of drop in this from the engagement numbers we saw in the first 2 years. Not dramatically though, but I think we were actually above the benchmark in almost all of them. And now you can see we're above in logins and completing lessons, which is great. And then we fall just below average in most of the other areas. But people are still weighing in 5 times a week. They're in there tracking 7 times a week. And discussion posts, we just do not have a lot of luck with social groups with our employees. For some reason, it's not something they pick up on. Where in other companies, I know that things have thrived because of a virtual social group. So I think it's hard to say, but the beauty of the Omada program is people can take from it what they want. And that was one of the key points we really liked when we were deciding which supplier to bring in. If somebody really likes interacting with a coach, they can have phone calls with them, they can chat with them during the day, or if the coach isn't a thing for them, they don't like it, they can rely almost solely on the lessons. And then similar with the discussion posts in the group, it's their choice. So, you know, we have a lot of different employees. We have a big contingency on the manufacturing floor. We have a lot of engineers, and we have a lot of other professions throughout the company. And so we really like that people can kind of, from this great program, craft it to what works best for them. So here's the 2018 outcomes. So this was a little bit disappointing. You know, through the year, we were seeing more and more enrollment, which was great. However, the results came down a little bit. So you see 3% weight loss, where it was up at 4% at 16 weeks, and then very similarly at 26. If I look at a bright spot in these outcomes, it's that the average weight at the end of 52 weeks is just a little bit less of the average weight at the end of 52 weeks in the years before. So it does seem like the weight that is lost is sticking better, if that's there's probably a better expression than that. But you know, the lasting results do still seem to be good. Okay, so our on-site program that I mentioned has been done by partnering with best-in-class hospital programs. We kind of developed some key components we were looking for, but we were really relying on the expertise of these hospitals. Something very interesting that we found that I will say, if anybody is considering bringing something specific to their company on site, is even though we found best-in-class programs, it was still a lot of work to bring it to our work site because those programs weren't necessarily experienced in doing that. You know, it was a program where people came to the hospital or the medical center. And so I think it shouldn't really be a deterrent, but it is just a caution to say, know that there might be a little bit more work in it. We saw consistent weight loss from these programs too, 3 to 4% at 12 weeks. Employees really loved it. The costs varied a lot. So, you know, the cost for a Southern California program compared to a Huntsville, Alabama program is dramatically different. And it is tough to sustain over the long term. So because there's much smaller numbers, you know, we are continuing them in 2 places and we put them on hold in 2 places. It's very possible we will bring them back, but we kind of ran through the interested people who could make that commitment to show up once a week in person. And so we'll probably bring it back at some point, but we were very pleased with it overall. It just, again, might be tough to sustain with no breaks for a very long time. And then I think I just have some closing words. So when looking at diabetes prevention programs or weight loss programs, we really have figured out that different programs work for different people. Family involvement can be key. So we do have spouses eligible for the virtual program. And in our on-site ones, they were eligible at 1 site because it had to be outside our security perimeter in order to do it. So, but that has helped tremendously, and we had a few really great spouse stories of how they both had success and like how they changed their lifestyles together, and so it's really neat to see. I would say the one area we're still looking at is children's health, to see if we can identify something to get the whole family involved. As I mentioned during the numbers review, we did see year-over-year drop, but then pick up, but changes in results. So we're still trying to work through if there is a magic secret sauce for it. We also are, I didn't bring in specifics on how we've impacted long-term health yet, because we are going to do a study with our claims this year. So we're going to look at participants in OMADA and how that impacts emergency room visits, prescription drug costs, overall health claims, to see if we identify some differences there. We did, for the very first time in 5 or more years, see a very slight downtick in our weight risk from our health risk assessment. And it's the first time in years. It's been going up, 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 up. It was very small, but it was promising. So we're happy with that, and then we'll see if there's anything more clinical that we can connect. Oh, no problem. And then just let's keep up with the market, because there's so many things changing, as everybody knows, that the programs adapt, new suppliers come in and out, and we do really think it's important to keep a balance between technology and human interaction. So we'll continue to work on that.
That's great. Christine, I think we have a question in the chat box.
Yes, one of our questions, a fantastic question. Is OMADA a nationally recognized DPP, diabetes prevention program?
Yes, they are. Yep. And another thing is they might have been one of the first, although I shouldn't say that. I don't know if they were one of the first. They also partner with health plans. And so we were out on the very early end with them. I think they've done some work with Humana already. But for other clients, they do submit claims and bill through claims, or work with health plans too, which I think has become really popular. And I don't know if at some point we may choose to do that, but we were kind of out early, and so we've just contracted direct with them.
Do we have any other questions for Tara?
Nope.
Okay, I'm going to give just another minute or so. That was really interesting, Tara, and it's so helpful to see the change year over year. That's not something I guess I would have anticipated either. So it's fascinating that you're monitoring that, and then I look forward to hearing once you've got results from your claims investigation.
Absolutely. Us
reports.
too. I've been very curious. So
good. So no further questions at this time. We will have questions at the end. And thank you very much, Tara, from the Boeing Company. I just want to confirm, do I have Ron and Sarah? Can you hear me? To make sure we can hear Ron and Sarah. Okay. Oh, I think they were with Bert.
Yep, and I'm just, they are yelling yes. They are confirming yes.
Okay, that you can hear us, but we can't hear you. So.
Bert's unmuted, Sarah's unmuted.
They're confirming they're not on mute.
Okay. So let's go ahead and unmute everyone right now, just to see if that helps.
Can you hear me? Judy.
Okay, I'm going to ask anyone else that might have their phone muted or their computer, if you can mute yourself, we want to make sure that we can hear Sarah and Ron. Okay, so let's begin. Sarah? Sarah or Ron?
Yeah.
Okay,
Hey, Judy.
I talked to Gabby, and she was aware of a part of this a little bit, and I answered for her.
We're looking to see if we can, okay, Sarah?
Yes, Judy, can you hear me?
Excellent. Loud
Excellent.
and clear.
All right.
This is Ron, can you hear me?
Take it away, guys.
Excellent. Well, thank you very much. Sorry for that technical difficulty. First off, I just wanted to start when we're on this slide. You might be wondering why you're seeing WellSpark instead of Care Management Solutions. We are actually in the process of going through a rebranding, and so our new domain will be live in the next few weeks. So we currently, in this moment, still operate as Care Management Solutions, and we have been providing workplace wellness and value-based insurance design solutions for the past 7 years. And so we've provided solutions to over 500,000 members, including the largest employer in the state of Connecticut. So today, specifically, we turn our attention to diabetes prevention, and we'd like to share our case study of how we customized a diabetes prevention program to target and influence a challenging population, those individuals who take care of our roads and transportation infrastructure. Judy, if we can go to the next slide.
This is Ron McClellan. It's great to be with everyone today. And this program really was born out of care and concern for our members. As union president, I saw many familiar faces that were separated from state service due to diabetes diagnosis, and then the subsequent loss of their commercial driver's license. I often thought, why couldn't we take a proactive approach with early intervention? And I've also participated in a healthcare cost containment committee in the state of Connecticut. And we had lots of conversations about programs to improve health outcomes and reduce costs. And when the discussion at that committee turned to diabetes prevention, I knew this was our opportunity for early intervention. And it really took a collaboration of labor, management, a committee of 15 people, along with the state of Connecticut Benefits Division and department administrators. And it was no easy task. It would prove to be well worth the effort, though. A diabetes prevention pilot program with commercial drivers that maintain the highways worked out to be a perfect fit. The population presented many challenges for us, for the participants and for the clinical staff that would coach them through their journey. If we could build success with this group, we would have a template to achieve good outcomes with any population. Next slide, please. So that presented some cultural challenges, and recognizing those challenges up front, we decided to have a focus group of members come in, and early on we set that up to get out ahead of those challenges. And in this focus group, it represented a good cross-section of our members, but we intentionally chose some likely champions and some certain contrarians to be part of the group. It really proved to be a goldmine of information and a great opportunity for the coaches to begin connecting with the workers in a profound way.
Absolutely, and being part of that focus group occurred after a 4-day snowstorm that we had in the state of Connecticut, and just like Ron said, it was a fantastic opportunity to hear directly from the source what concerns they had, what opportunities they had, and really just gauge the temperature for the program. Some of the cultural challenges that came through in that focus group that we knew that we had to proactively solve for in the construction of our program, one was trust. So we knew and we heard that individuals might be hesitant to either participate in the program or be 100% truthful with the opportunities that they felt they had. And that came from a place of fear that somehow the information in this program would be used to target them. So what we did to combat that challenge was to make sure that we had combined support for the program from both leadership and the union present in every aspect of the program that we did. We actually kicked off our program by traveling around doing some informational presentations, and both union management and labor management were at all of those sessions to dispel any issues related to trust. We also came directly into the place of work. So we were delivering information. We came directly to where these individuals worked day in and day out. So bringing it to them versus having them go somewhere also helped, you know, carry through that sentiment of trust.
I think that was everything, Sarah. We realized with that population, their work responsibilities and everything that they had going on, that the only way that we were going to get participation was taking it to them.
Absolutely. You know, and to speak on that, so we recognized that we were going into, you know, garages all throughout the state. So there were decentralized communications and very much some isolated workspaces. So we heard that, and we knew that people were working in silos, whether they were geographic or job type in nature. You know, our coaches learned very quickly that the lives and challenges of mechanics were very different from those of loaders, and all of those were different from the drivers. So, you know, we had to make sure that we were able to have a consistent way of communication so nobody felt like they weren't getting the message or didn't have the opportunity. So we learned that we could leverage some of the communication channels that were existing within the workforce and the population, but we also knew that we had to create some of our own so we could make sure that program communications continued.
Sarah, one of the other challenges as well was also in conversations that I had with management, getting them to understand the nature of the work that these folks were asked to perform, and the fact that doing that very work made them sick in a lot of ways and presented some real serious health challenges. So those discussions early on in getting management to take ownership of that and actually decide to invest with their employees in their health and well-being was a big factor.
Absolutely, and to speak more to kind of the profile of the workplace and the workforce that we were going into. So this was a public sector population. We featured an average age of 49.4, and we were also overwhelmingly male, about 94% male. We had initially suspected and later confirmed that our population was not digitally savvy, and overall felt very left out and overlooked by most health programs. To speak to the educational level, most of our population had, you know, graduated high school. There was very little college or trade school. So we knew that we had to create a solution that catered to that specific population. We knew that while most of them had smartphones, the utilization of those was very, very basic. So we had to make sure that our lessons featured multiple modalities. We did favor a lot of in-person, but we did also do some follow-up via digital and telephonic solutions.
And a lot of that became very evident right out of the focus group. When we sat down with the coaching staff and our members, they were able to have a real productive dialogue about the things that they face and how they were situated and what things would work and what might not work.
Next slide. All right, so the program kickoff. So, you know, currently we are running sessions out of 11 specific employer sites. And we worked with the employer management to establish a consistent schedule for sessions, making sure that we kept the same day of week and the time of day. And this really allowed for greater adoption into the overall culture of work and work site for those individuals. I can tell you, you know, we are approaching, you know, the 12-month anniversary of our program start off, and our coaches absolutely are part of that culture. Not only do the people in the program know us, but their fellow coworkers, the supervisors, everybody knows who we are when we go on site. So we really have sort of infiltrated into the full culture of our employer work site.
I can say this feedback that I got was that the workers felt more comfortable with this coaching staff than they even did their own supervision or management.
You know, just as Omada's does, our program does follow the Center for Disease Control National Diabetes Prevention Program standards And we leverage, the CDC has a couple of different curriculums out. We leverage the Prevent Type 2 Diabetes Prevention Program curriculum. And so this curriculum, it focuses on distinctive behaviors and looks to increase the knowledge of participants as it relates to their own lifestyle behaviors and those links to either increasing or hopefully reducing the risk for prediabetes. What we did, we started in our program with an emphasis on knowing your numbers as well as health literacy and numeracy. So we wanted to make sure that all of our participants knew the importance of a basic biometric lab panel, including fasting glucose and hemoglobin A1C, understood the results and how those results translated into their health status. Once we made sure everybody understood their numbers and what that meant for them, curriculum lessons also featured topics such as how to get active to prevent type 2, how to read a food label, how to cope with triggers, and even the importance on sleep on overall health. Our coaches, they used that curriculum, but then we made sure that participants partnered with coaches to understand how they could take those overall lessons from the curriculum and implement them into their own particular lifestyles. I think generally, you know, for the people on the call and generally in life, we find that most people kind of know what they should be doing. The hard part is figuring out how to do it and how to keep it going long term. So that's really where our coaches were almost the secret sauce or the special sauce for helping participants figure out how they were going to do that. We didn't always get the right combination on the first try, but that partnership and that support that the coach gave participants allowed them to be able to work through the challenges that they faced.
I think some of the programs that were and events that were run with the members of taking hikes and participating in 5Ks, you know, the story of Larry the mechanic, the typical guy with a flannel shirt and work boots, walking a 5K and us cheering him at the finish line was really profound.
Yeah, and Ron's talking about, you know, so just as we had primary access to the employee, but we know that, you know, the employee doesn't live in their own ecosystem, that they have their family, they have their coworkers, they have their friends. So we made sure that throughout our program, we provided opportunities for not only family inclusions, but friend group inclusions, as well as coworker inclusions. And we made sure that, you know, that the definition of family varies widely. So whether that was single parents, whether that was people taking care of, you know, potentially elderly parents within the home, sandwich generation, living with friends, different things, we made sure that as we went through and talked with individuals, we, you know, formulated customized plans based on their own needs. We did also look to get people more involved in their community. You know, one of the biggest factors that we face right now with wellness is the concept of people being lonely. You know, we're more connected, you know, potentially than we ever were, but a lot of people are more lonely than they ever were. So we leveraged, you know, utilization of state parks throughout our homeland, and we organized hike days for people to be able to go out, get into nature, and see more of our state. We leveraged opportunities with community 5Ks. We had individuals who had never thought about ever participating in a 5K, and not only have they participated in many, but they've actually run them. And so that was through, you know, guidance by their coaches and getting more involved in the community. So I think it just showed the great nature of making sure people are connected.
And the looks on their faces when they accomplish something like that is something that sticks with you.
Next slide. All right, so what were really the factors to success? So what makes our program different? We take the time to build not only trust, but more importantly, rapport with our participants. We not only care about their progress in the program, but we care about their overall happiness as well. And I think that's something, this quote right here, you really care about us. That's something that we heard directly. This was a population that very much felt that they were overlooked. They had that feeling. So us going in and really spending the time to hear them out, to hear their challenges, and then come up with solutions that fit, they really, really, really appreciated that. So how did we build such intense trust? We asked the right questions. at the right times to get to the root problems. And so how did we do that? We did that through our use of behavioral diagnostic modules. And those leverage questions scientifically proven to assess social determinants of health. And those helped our coaches equip participants with resources and solutions for life. These models, they really were like the lightning rod to uncovering challenges that people faced in their lives. Sometimes they weren't even aware for challenge. They were getting frustrated that they couldn't make progress, but they never took the time to really understand the challenge. So we use these modules to build an individualized profile for each of our participants, highlighting both the areas of opportunity as well as the strengths that they already had that they could utilize to make success in the future. And coaches worked personally with participants to help solve for issues and mobilize resources. So what does that look like in actual life? So one of the modules we utilized, and we utilized early on in the program, was health literacy and numeracy. Like I said, you know, a lot of people face challenges with reading or understanding numbers. So how did this help us? Well, it helped us to identify that majority of participants in our program did not understand how to read a food label, and specifically portion size and number of servings in the bag or box. So what did we do? That absolutely changed how we taught how to read a food label. We spent a lot more time. We practiced teach-back methodology, and we continue to follow up with people on food labels and how they're using them. We also use these modules to help us have those sometimes more difficult conversations about behavioral health. We actually, as a coaching staff, waited to deploy these modules until after we had established rapport. We wanted to do that because A, we didn't want to come out of left field asking about mental health, and B, we wanted to make sure that people understood and trusted us so that way they would actually utilize resources if resources were needed. And so because we waited, when we actually went through and deployed those modules with participants, we were met with a very open conversation and a general appreciation that we were talking about this. We were really astounded with the feedback that we got and the openness that people were willing to have with us. And as a result, we've actually made a number of behavioral health referrals. And I think generally, you know, behavioral health or employee assistance programs are a very underutilized benefit. And so because the coaches had this rapport and trust with participants, participants felt like they could go ahead and utilize those resources.
I just want to say too, I know this group very well, and they are not typically the type that open up. So getting through that barrier was a huge accomplishment.
Mm-hmm. And like I said, you know, it goes back to the family too. So we knew that through every aspect of our program, like what challenges they had, and then linking them up with resources. We spent a lot of time on food. It's everybody's favorite thing to talk about. So we did a lot of recipes. We did recipes that could get your kids involved, recipes that you could bring to your family functions. We did an entire packet of recipes just for the holiday season. So we did a lot of customization in our program to really make sure that people felt empowered, that they had the resources available, not only to make the health improvement now, but to carry it on into the future.
And one of the challenges of a long 3-day snowstorm is the availability of food in restaurants that are open, and the members themselves and the coaching staff reached out to restaurants and had them rework menus and provide healthy choices. So,
next slide. So our results. So thus far, our program has been successful at both reaching a difficult population and producing sustained results. So, you know, we are a CDC accredited program in pending status, and so we do track CDC program metrics. So those are average weight loss across all participants. And so this metric is assessed by comparing the first weight of a participant in the program, so kind of session 1, month 1, to the final weight of the participant in the program, session 26, month 12, so a full 52 weeks later. And in order to meet CDC standards for certification, your population must achieve at least an average of 5% weight loss across all participants You can see, you know, we are trending there, and we've lost over 1,000 pounds to date. And in our program currently, we have less than 100 people. So that is a significant amount of weight, you know, half a ton to be lost by a challenged population. CDC also measures attendance at sessions. And so in order to be included in evaluation, participants need to attend a certain number of sessions. When we went to make our first data submission to the CDC, they actually came back and questioned our attendance because we had such good attendance. They thought we had actually made a mistake in our data entry. But we actually, people came to our sessions, and we did that proactively. We knew that we were gonna have to be flexible with this population, and so we did that, and that's how we were able to get people to have such great attendance. While hemoglobin A1C is not a metric that is measured for CDC certification, understanding this valuable lab result is something that's key in this program. So what we did is a couple of weeks into the program, we actually brought a screening opportunity on site as part of our sessions. And we will be doing that again at the 12-month sessions as well. Being able to not only identify people, but also link them back to their primary care physicians. So coaches not only help people understand what that hemoglobin A1C result means, but actually empower them to call their primary care and make sure that that gets into their clinical chart as well. Of note with the CDC, they do require that a certain percentage of your population be proven to have prediabetes based on a blood test. So that's a fasting glucose, a hemoglobin A1C, or a diagnosis of gestational diabetes during a prior pregnancy. We currently have 59% of our population that's been identified as eligible based on a blood test. And we don't have any gestational diabetes, again, because of our 94% male. So just as with the Boeing program, people who have been proven by blood have a little bit more skin in the game. So about 60% of our population has been there. Our results to date with this population have been exciting and meaningful. We really gained experience with implementation and learned valuable lessons on reaching challenging populations. We have continued to focus on program improvement, even during the implementation phases, and have leveraged lessons learned and enhancements into not only our in-person program, but also our digital delivery option. We actually officially filed for our Life Coach supported fully digital program with the CDC on April 25th. So that program is both a platform as well as a mobile app solution. All right, so some of the key lessons learned and our best practices going forward, really be honest when you assess your workforce. Like Judy had talked about in the building a business case area of the toolkit, you know, sometimes you have to ask the somewhat hard questions. You know, do the jobs your employees do put them at a higher risk for health issues? Are they sedentary? Are their jobs causing a high amount of stress? These are all things that you have to understand in order to bring in a health program that is going to match them. You know, pick a program that will work for you and work long term. Make sure that your program dives deep into individual needs and provides a robust solution versus just scratching the surface. Employees need to feel like that program really matches them, is not a one-stop solution for everyone. Be sure, again, just as we've done, just as Ron helped us do, to get not only initial, but ongoing buy-in from management, including supervisors, those people who are boots on the ground day to day there. As these programs focus on making sustained changes to behaviors, it's important to assure you have those supervisors on board for not only program activities, but also activities going into the future. Thank you. Do we have any questions?
Yes, we have two questions from our participants. Question one is, were the employees allowed to attend the on-site classes or hike days on paid time, or was this on their own time? That's question one.
So we knew that those sessions were going to be extremely important. So I had early on had discussions with management about carving out some time on the clock, and they were actually held on the clock. And I believe management saw the value in that early on and provided that option for us.
And question 2 is how many employees are included in the 85% that finished the program?
We had about 130 individuals that originally signed up for the program. Not all of them were determined to be eligible based on the CDC standard. So the 85%, that's of the roughly less than 100 people that we have that are sustained in the program and have been sustained and engaged in the program for almost the past 12 months.
And I have a question. This is Judy Hearn. What do you think was key in having the employees say, yeah, I want to be part of this, compared to maybe other employees who should have been involved but didn't? Why do you think some took a step forward?
Well, one factor with this population is that they are commercial drivers, and if they should become or have a diagnosis of diabetes, they potentially won't be able to get their commercial driver's license renewed because they have to have a certified medical examiner approve them every 2 years. So that's a whole nother level of concern. And with any group, you know, you hold an education session, some people get it, some people don't. But I think it hit home pretty quickly that, hey, if I'm pre-diabetic, I may be in jeopardy of some bad health outcomes and in jeopardy of losing my job.
Judy, and this is Sarah. We actually, once we started the program, we actually had our own participants that were referring their coworkers to the program. We had people who were, you know, pulling in somebody by the hand saying, you know, hey, Jim, you really got to be a part of this. So I think that really speaks for it, that, you know, it's almost that internal referral. So that's really when we knew that we had broken in.
Yeah, I agree. Prior to my time at the Midwest Business Group on Health, I was the health and welfare manager for a large manufacturing organization. And we were fortunate to have some on-site clinics with occupational health nurses there. And when we rolled out a diabetes management program, it wasn't pre-diabetes, but it was actually managing those with diabetes. Those occupational health nurses were key in reaching out because they knew the employees. They had to go to them for their hearing tests and for other things during the course of work. So another suggestion in how the people within your own organization can really make a difference. And when one person gets excited, they can encourage others. And I think, Tara, do you have any other comments that you might want to mention along those lines?
Yeah, we partner with a lot of our internal partners and stakeholders. So we do partner with health services. We have, although less drivers, we have, oh gosh, I'm going to get the fall protection program, especially for painters on the planes. So there are weight limits for those too. So we do have some connection in some of our jobs to it also. So we've partnered with health services. We have on-site what we call well-being focals. They run a fitness center and are there to promote programs, so they'll talk to employees. We've slightly through HR, but that's not really where the big connection comes from. We also have a program called Industrial Athlete, which is basically like almost like athletic training, but for individuals' jobs. And so those trainers establish really good relationships because the only thing they're in it for is their health and helping the employees stay feeling good to be able to continue working. And so they often refer to. And then we see a lot of success off of employee testimonials. Because of our scale, we do a lot more things electronically, I would say, but we have had one employee tell another employee, and the testimonials are a good way that we kind of communicate the stories out.
Great. Do you have another question?
Yes, another question has come through. This is specifically for Ron. Ron, are you looking to invest in other departments?
So my understanding that the success of this pilot program is that there are current discussions going on to expand it to the roughly 50,000 member population of the Connecticut state employees. And the the next phase likely to include state police and corrections because of the health challenges they face.
That's great. That's really exciting, and we hope that that you'll keep us posted. As I mentioned before, we are going to be doing this webinar again on May 30th. So for those of you on the line, if you have colleagues that were unable to make it today, we're going to do two things. We will be providing copies of the slides to our participants, and I think we'll also be able to post that on the Midwest Business Group on Health website. And in addition, we will have the recording of the webinar. But you can find on our website where you can enroll or register for the May 30th program. And then also in June, on June 25th, we will be in way south Illinois, in Carterville. I've been told, I've not been there before, I'm looking forward to it. It's between Carbondale and Marion, Illinois, and it's further south than St. Louis, just because that's how the state is created. So that's kind of exciting. So we are going to do something very similar in person. We'll have some hands-on opportunity to work with the toolkit to give people one-on-one instruction if they need or want that. And then we'll also be having an opportunity to hear from several different DPP providers. And I'm hoping that we will also have a session on obesity and why that is just so important in helping to eradicate type 2 diabetes if we can get a handle on our collective weight as a country. So one more check on our chat box for questions. Okay, not at this time. You know what that means? You get time back in your day. So I want to thank all of you for participating. If you have any questions, please feel free to reach out to me at jhearn@mbgh.org or be very comfortable in picking up the phone and giving me a call. Again, one more plug for our annual conference that is next Wednesday and Thursday here in Chicago at the Mid-America Club. Our key theme there is employers are the driving force. Trust and accountability is our focus, and we're very excited to bring this to anyone who's interested. So we look forward to talking with you in the future and being a resource to you if you need more information, if you want to offer a diabetes prevention program at your workforce, feel free to give me a call and I can connect you with appropriate providers and answer questions and so forth. So again, thank you